Thank you very much for this kind introduction, and thank you for coming here today and for inviting me to give a little presentation on all the central changes we see in the visceral pain system in chronic pancreatitis patients. So what I'll do is try to take this from a sort of a basic level to a more clinical level, because I'm mainly working with clinical experiments. So the questions I'd like to address in this talk is, first of all, central sensitization. Is that something we can measure in patients from a clinical perspective? And then, of course, we'll see if it's really present in chronic pancreatitis. And we'll try to look into data that explains whether it really means something for the patients or whether this is just really an EP phenomena. And finally, I'll touch briefly upon treatment, but this will be covered later on by Dr. Drews in his talk at the end of this session. But in order to understand what's going on in the central nervous system in the context of chronic visceral pain, it may be good to know what's going on in a normal sort of acute pain condition. So, for example, if we consider acute pancreatitis an example, the inflammation in the acute inflamed pancreas will generate activation of nociceptors in the periphery. This will again be transmitted to the spinal cord and ascend via the ascending second order nerve to the brain, where it's ultimately perceived as pain. This may again activate descending modulatory pathways that in the normal physiological state likely will be inhibitory, whereby the brainstem exerts some sort of negative feedback loop. And this is a way that the brain can sort of control the incoming afferent volley on the spinal level. However, in the context of chronic pain, for example, as example here by recurrent acute pancreatitis, chronic pancreatitis, we've already heard from Ekin that there's a lot of things going on in the periphery that can be summarized very crude in pancreatic neuropathy sensitization, but this again may lead to changes in the central pain pathways, where we see different changes at the spinal level, classical central sensitization, at the supraspinal level, where we see patterns of abnormal brain activities, and this may even go into change the structure of the brain, so we have structural alterations, and finally also change the way that the brainstem and brain modulates pain on the spinal level again. So we have a lot of different manifestations in the central nervous system. When it comes to central sensitization, this has been defined as a prolonged but reversible increase in the excitability and synaptic efficacy of neurons in the central nociceptive pathways. From basic studies, we know quite a lot about the mechanisms. These involve, among many, changes in the activation kinetics of the glutamate receptors, the NMDA receptors, the AMPA receptors. It changes the trafficking of these receptors into the postsynaptic neuron. It changes the ion channel properties with hyperexcitability, and also we'll see loss of inhibitory interneurons and GABA-mediated transmission in the spinal cord, whereby everything becomes more hyperexcited, sort of, to say. The problem from a clinical perspective, however, is that we do not really have access to these mechanisms in the clinic at the bedside of the patients. Normally, the patients are not big fans of brain biopsies or clamp experiments in the spinal cord, so we have to do something else. And what we can do is that we can use experimental pain models, what we sometimes call quantitative sensory testing, to try to study phenomena associated with central sensitization. The idea here is that we consider the pain system as a black box. We cannot go into this black box, but we can stimulate it on the left-hand side by experimental stimuli, where we can control the modality, that is, what kind of stimuli we use. That could be, for example, pressure stimulation, mechanical stimulation of the gut, visceral distensions. It could be heat, cold, chemical stimulation, etc. We can also control, in a very tight fashion, the intensity of the stimulation. We can control the frequency. We can control where we stimulate. And on the other side, we can then ask the patient what happens when we do these stimulations. And thereby we can get an idea of what's going on in the pain system by controlling the input and measuring the output. In doing that, we normally do what we call stimulus-response curves. So if we stimulate a control, we'll typically see that when we go into the noxious range, they'll begin to report pain. And this ultimately defines the pain thresholds and the tolerance thresholds. However, if we have a sensitized pain system, we may see a leftward shift in this stimulus response curve, where we have reduction in pain thresholds, reduction in tolerance thresholds. So we now have what we call a hyperalgesic state of the pain system. So the patient reports more pain for a given stimulation intensity as compared to their healthy counterparts. In the more extreme situations, we may even see that the patients report pain in the presence of stimulations that are normally not perceived as painful, and that's what we call allodynia. So by doing these stimulation response experiments, curves for different kind of stimulations in different tissues, we may get an idea of the state of the pain system, whether there's a hyperalgesic state. And this could then indirectly point towards central sensitization. Then the question is, where should we stimulate? For example, when we are pancreatologists, it's not normally very popular to do ESPs and stimulate directly in the pancreas. So we have to do something else. One thing we could do is we could try to study the sensitivity into tissue surrounding the pancreas, because it shares spinal segmental innervation with the pancreatic gland, so we'll likely see secondary hyperalgesia in these tissues. But even smarter, we may also use the concept of referred pain, because we know that there's some somatic and visceral convergence on the spinal cord level. So the increased pain responsiveness, the hyperalgesic state, may also be reflected in the referred pain areas of the patients. So this is very useful in the clinic. So we'll typically see that the patients with chronic pancreatitis, they have an increased pain responsiveness in the referred pain area, and we also see that the referred pain area often expands in the presence of central sensitization. In the most extreme cases, we sometimes see that the sensitizations change from spinal level and go up through all the full nerve axis up to the brain, so we now have a widespread sensitization that can actually be detected in more or less all over the body. It is, of course, absolutely crucial that when we do these experiments that we are in total control of the test paradigm. So it's fundamental to do test-retest studies, and we have done that extensively in healthy controls, and now we have also done it in patients and shown that reproducibility separated by 1 week is quite stable in these patients, at least when it comes to the measures about pressure and electrostimulation of somatic tissue. So we think we have a model that is really useful in the clinic. We have applied these models, of course, to chronic pancreatitis patients. On the left-hand side, you can see two experiments, two papers, where we used electrical stimulation of the upper gut based on this secondary hyperalgesia phenomena. And indeed, we were able to show that the patients with chronic pancreatitis, they had lowering of the pain thresholds in a hyperalgesic state. And similarly, quite striking, we also found that when stimulated the lower gut and rectus sigmoid, we found absolutely the same findings, lowering of pain thresholds, lowering of tolerance thresholds. And that was even observed in patients that were on opioids that would actually counterbalance this. So this is actually, I think, proof of concept that we have hyperalgesia in these patients. But again, it is a little bit cumbersome to stimulate within invasively using endoscopic approaches. So we have also tried to do more simple models where we have stimulated the somatic tissues, again, based on this theory of secondary hyperalgesia. And again, we could find that the patients, they actually had decreased pain thresholds, tolerance thresholds to both mechanical and electrical stimulation of dermatomes. And even the most simple test we have done so far is asking the patients to immerse their hand into ice-cold water and then rate their evoked pain responses. And again, you can see on the downside, the left corner, that they react with a very much more exaggerated pain response compared to control. So this is actually a test we call the cold pressor test that can be used maybe at the bedside of the patient to see if there's any sort of evidence or signs of hyperalgesia. Another way to study central sensitization, in addition to controlling the stimulus intensity, is to control the stimulation frequency. And this relates to the phenomena of temporal summation. This is a little bit complex, but I'll try to take you through this slide. So, if we separate the stimulations by, for example, 4 seconds and use exactly the same stimulation intensity, we'll have exactly the same pain rating from the patients from stimulation to stimulation. This is because this is normally mediated via the AMPA receptor in the synapses, where the block of the NMDA receptor. However, if we decrease the frequency, increase the frequency stimulation down to 1 second, so we stimulate with a frequency of 1 Hertz, we may see this exaggerated pain response even in healthy controls, meaning that even though we use the same stimulation intensity, when we go down in stimulation frequency, we see that the pain response rises. And this is because the NMDA receptor that is normally blocked by a magnesium ion in the pore, it's actually become activated due depolarization through all this rapid stimulations, and then the magnesium block is removed and we have activation of the NMDA receptor. So we now have two receptors to play with when we see this. So in the context of chronic pain, we see very often that we have this central sensibility, a central sensitization that changes the ion channel properties, the NMDA receptors, and that means that the magnesium block is now out, so the NMDA receptor is active. So, in the context of chronic pain, we'll typically see that this temporal summation phenomena is exaggerated as compared to healthy control. So this is another way to look into central integration and sensitization. Using these paradigms, we have shown nearly 10 years ago, Georg Dimsewski, that there is an increased temporal summation in chronic pancreatitis patients, and recently we have reproduced these findings using the same stimulation paradigm, but stimulating both control area and the pancreatic area, and again we see exactly the same. So it seems that this could also be a useful method in the clinic to look into central sensitization. Finally, we can also look into these descending pain modulatory pathways that we have discussed initially. I'll not go into all the details about the mediators and the pathways, but what we can do in the experimental setting is that we can try to induce this descending inhibition by subjecting the patients to a prolonged, sustained tonic pain stimulus. We often use, again, the cold pressure test where the patient immerses the hand into water, and a way to try to quantify this descending inhibition is then to apply a test pain before and after we induce the descending inhibition. And by subtracting these two different pain thresholds, we can then get an idea of the responsiveness of this modulation. We have looked into that in chronic pancreatitis patients, and when we looked in the controls, we could see that they could actually tolerate 30 to 40% more pain after we had induced this descending inhibition by the tonic stimulus. But when we looked into the patients, we could see that this response was blunted, and in some patients we even saw facilitation. So this means that we see often a transition, in the transition from acute to chronic pain, that the descending modulations change from inhibition towards facilitation. So this is again another way that we can study these phenomena at the bedside in the clinical situation. So far, we have only discussed pain models where we ask the patient to rate the outcome. But it is also possible to do some more advanced experiments where we try to get an objective correlate of what's going on. That could either be using electrophysiology, for example, evoked brain potentials, or even functional MRI. I'll not go into details about all these methods, just give you brief examples due to time limitations. For example, again, the same experiments as we saw before with electrical stimulation of the upper and lower gut. Simultaneously with these stimulations, we recorded the evoked brain potentials in the brain of the patients, and were able to see that in chronic pain patients we have an exaggerated response in the evoked pain potentials, probably again reflected central sensitization integration. And interestingly, you can see when we try to modulate where this electrical activity was generated, we could see that it was confined to the visceral pain matrix, if you like that, the idea of such a matrix. That's another story. But at least we could see that there was activity in the cingulate, S2, and the insula, both following upper and lower gut stimulation, and we could see that it actually changed the position and the activities in these areas, which likely reflect some sort of functional reorganization in these patients. Another experiment where we used these more advanced methods looking into electrophysiology was based on the phenomena of habituation. In the normal pain system, if we stimulate with long intervals between the stimulations and prolonged times, we often see that the responses go down very slowly. That's what we call habituation. But in the presence again of sensitization and lack of descending inhibition, we may see habituation to a lesser degree. So we designed an experiment, a little complex, where we stimulated the pancreatic area, again as a proxy of pancreatic stimulation. We stimulated a control area, and in addition to these subjective pain ratings we discussed before, we also obtained cortical heat evoked potentials. And what we found were that we did a simulation sequence of 3 series of 30 stimuli, and what we found were that the pain scores, both following pancreatic area stimulation and forearm stimulation, went down as expected in the intensive controls. They habituated to these stimuli, but the patients, they actually remained stable, or some of them even increased. So we have a lack of habituation in these patients when it comes to pain scores. And interestingly, when we looked at the evoked brain potentials, this was actually also reflected here in the objective correlate, where we could see that in patients the amplitudes went down, but in the patients we saw some sort of amplification, and that was most pronounced in the pancreatic area, following stimulation in that area. So here we have an example of how we can assess these things using objective methods. The structural changes in the brain may also translate into structural brain abnormalities. These are 2 studies from a good colleague in Pregabalin, sitting in the front row here, and he can touch briefly upon them in his talk. But again, we have looked into the brains of these patients, looking into using 2 different techniques. One technique is based on diffuse weighted imaging, where we can get an idea of the microstructure of the brain. We found changes in most of the areas that are normally considered as a part of the pain matrix, visceral pain matrix, and interestingly, we could actually see that many of these changes correlated with the clinical symptoms of the patients. On the other experiment, study on the left-hand side, we studied the cortical thickness in the brain of the patients, and again, in the same areas, we found that there was a shrinkage of the brain, and again, these shrinkage was associated with the clinical pain scores of the patients. So we seem to have a structural correlate of the functional changes. Then when it comes to mechanisms, we are a little lost, because we can't really study that as extensively as our peripheral partners. But we could speculate that these functional changes at least may represent some form of supraspinal central sensitization. But of course, there may also be a lot of other explanations as listed here. When it comes to structural changes, neurodegeneration, which also was mentioned by Ekin, may be a very conceivable explanation due to glutamate-induced exoptoxicity. This has been studied extensively in animal models, and that's likely a relevant mechanism here. But of course, when it comes to chronic pancreatitis, we must not forget about the alcohol, the diabetes, etc. That could also be of relevance, although we have tried to control for these confounders by using some statistics. So, to sum up central changes in chronic pancreatitis, we see a lot of different levels. We see central sensitization of the spinal cord, we see on the supraspinal level structural alterations and changes in modulation. So it's rather a complex phenomenon. The next question to address is, of course, does these changes really associate with the clinical phenotype of the patient? This is a study from Denmark, actually, some of our good colleagues in Odense, who studied 400 chronic pain patients. They were not all, of course, chronic pancreatitis, but they had all kind of chronic pain syndromes. And what they did, they were to try to map their central processing using descending modulation paradigm and using the temporal summation paradigm. So you could say on the x-axis you have the modulation, on the y-axis you have central sensitization. And then they tried to separate them into 4 groups, those with abnormal of both systems, those with normal systems, and those that had abnormalities in one of the 2 systems. And what they found were that the patients that were characterized by impaired modulation and facilitated temporal summation, that is central sensitization, they were also the patients that had the most severe clinical phenotype. They reported more pain, they reported more painful areas, loss of quality of life, etc., etc. So there seems to be an association between the central processing and the clinical phenotype of the patient. This has also been studied a little bit in chronic pancreatitis patients. This is a study from our Dutch collaborators where they classified the patients with chronic pancreatitis based on something we call the Mannheim. I'm not sure you're familiar with that, but that's a clinical staging system where we can stage the patients depending on exocrine, endocrine insufficiency, other complications, and pain. And what we can see here is that those that had the most severe Mannheim class, they also had a lot of hyperalgesia, both when it came to electrical and pressure stimulations. Recently, one of our PhD students has also looked into this time modulation, and tried to associate it with the clinical pain scores. And as you can see here on the graph, if we adjust the modulation capacity correlated against daily average pain intensity and adjusted for diabetes and opioid consumption, we actually have a quite close association here. So again, this is proof of concept that there must be something, it must mean something for the patient. It actually reflects something that is clinical meaningful. So the last question is, of course, can we then target these central changes? We have already discussed very briefly some of the mechanisms that are associated with central sensitization, namely the changes in the activation kinetics of the NMDA receptor. This can be antagonized by ketamine. And we have also talked about changes in ion channels, particularly the presynaptic calcium channels that can be modulated or blocked by GABA pentoids. And also another remedy may be neuromodulation. I will not talk about that today, but that's a new kid on the block, and I think we're going to see much more about that in the future. So for ketamine, we only have only a single line of evidence to support that it's effective in chronic pancreatitis. This was an experimental study where our Dutch colleagues infused ketamine in patients with chronic pancreatitis and then assessed their pain thresholds to pressure stimulation. And what they could show in crossover design were that they were actually able to reverse the hyperalgesic state during and immediately after the ketamine infusion, while there was no really any response in the placebo arm. So this was in a sort of more like a proof of concept study, but it was not designed for clinical endpoints. So therefore we decided that we thought this could be very interesting to look into and use ketamine for clinical treatment of the patients based on these theories. So we designed a rather extensive protocol, unfortunately too extensive because we had to terminate the study due to lack of recruitment. Probably were a little bit too ambitious with too much imaging, too much pain stimulations and so on. So we have to learn from that, and now we are trying to take the protocol down to a more realistic stage and maybe try to set it up in multi-center fashion, but we'll see. A more successful history comes from our previous studies on Pregabalin, one of the GABA pentoids that can modulate the calcium channels in the presynaptic neuron. We used this some years ago as an adjuvant analgesic for the patient's normal pain treatment. So they just had either placebo or Pregabalin on top of whatever they had. And then we followed them for 3 weeks and could see that actually Pregabalin induced a clinical meaningful response in the patients. But again, we could see that we should actually treat 10 patients in order to obtain 30% pain reduction in one. And that's probably because we just included everybody. So it could probably have been a good idea to look into, for example, enriched enrollment and study if they really had evidence of sensitization and then only enroll patients with that. But that's another story. But one thing is the primary endpoint, pain intensity. If we asked the patient, that was one of our secondary endpoints, about what do you think about your global health situation now, they actually had a response that was much more in favor of Pregabalin as compared to placebo. So this is a drug we use quite often to treat patients with chronic pancreatitis pain. The downside is, of course, the side effects. Typically CNS related, they feel drunk, they feel lightheaded, but importantly, they are often very mild to moderate, and importantly, they often wean within a week or two when we wait for the analgesic effect. So it's very important, if you want to treat the patients with the kind of drugs, that you very carefully explain to them that you have to go through a week or two where you may not really benefit from the drug, but experience side effects, but there's light at the end of the tunnel. It may be useful, for example, after 2 weeks or something like that. That's important. When we did the Pregabalin studies, we also did these experimental pain paradigms before and after treatment. And this was simply to look into sort of a mechanistic understanding of how the drugs worked in these patients. And what we could demonstrate were that we actually were able to reverse the hyperalgesic state in the patients, both when it comes to visual stimulation. Here we used electrical stimulation of the rectosigmoid, but also when we used these somatic pain stimuli, pressure and electric stimulation, while we did not see any changes in the modulation. So that's really compatible with what we know about the mechanisms. So again, Pregabalin probably works through activation or deactivation of these calcium channels. It has an anti-hyperalgesic effect and also translates into an analgesic effect in the clinic. So to sum up, central sensitization and pancreatitis, can we measure it? I think we can. Is it present in chronic pancreatitis? We think it is. Does it mean anything for the patient? Yes. A few lines of evidence suggest that. We have to look more carefully into this in the future and try to develop tests where we can apply it at the bedside and go into a much larger patient population, as you saw from the study with 400 chronic pain patients. And finally, can we treat it? We have pregabalin, gabapentin, maybe ketamine, but we are definitely waiting for new interesting drugs. As Ekin suggested, and also maybe neuromodulation may be a very interesting remedy to look into in the future. And actually we are setting up a trial now where we look into vagal nerve stimulation and see if it really can change the pain symptoms in chronic pancreatitis patients. And with that, I would like to thank you for your attention.